Um, these are similar to my disclosures from yesterday, but I do have a couple of additional things that are in there. I was part of the UW GME office had a collected group of program directors when they went through their second collective bargaining agreement, and I was a part of that sort of advisory group. I'm also a former program director, but handed that position off about a year and a half ago. And as an SAU member at large, and also as a new nominee to the RRC, none of the things that I'll talk about today are they're all my own personal opinions and experience. So if you've been paying attention, the resident unionization has become sort of a hot topic button. It's become a lot more popular and a lot more discussion. I think it's not difficult to conceive that as this sort of tidal wave of programs move towards unionization, that eventually most programs, or maybe even all programs, I think if you look at the diversity of the programs that have moved to unionization, it touches all program types. Big academic centers, even programs that are started by private health companies or insurance companies, small community-based programs. I mean, it really runs the entire gamut. And based on 2023 data, about 20% of House officers and House staff in the US are part of a union. I gave a talk similar to this about 2 years ago, and that number was 15% instead of 20%. So we're definitely seeing more and more programs moving that direction, and it's very rare, though it does happen, that a program is unionized and they change their mind and go the other way. You can see this is just some of the examples of programs like Montefiore, Stanford, Penn. It really runs all across. These are just a couple of examples of news articles that I pulled that have some explanation and often quotes from residents about what they're pushing for, or what it is that they're the most interested in. I think the first thing we always think about as an institution or as a program is that it's salary and maybe benefits, but actually for a lot of the programs, the other things that are outside of salary and that probably sit more squarely in the benefits section can often be a bigger driver. But oftentimes it's way more than just the compensation. This on the left side here is just an example of some things that were pushed for as UCLA is going through their process of attempting to unionize. Fertility benefits, paid parental leave, campus housing, food, a wellness fund. Really the world's your oyster, almost anything that you can think of. And as these programs often partner with a union organization like CIR. They have a recipe of things and a lot of experience helping programs go through the process of unionizing. So I think less and less are programs trying to do it on their own, and oftentimes they're partnering with an established national-based union or representation that can help to provide some guidance about some things they may have never thought of to ask for, and ways to go about some of the process of negotiation. I did put this top right little bubble up because being part of the union isn't free. That 20%, the latest numbers that I saw were that about somewhere around 30,000 residents are unionized. And the membership to be parts of the union is about 1.5% of their salary. So if the average resident is making about $60,000 a year, which is what the median is across the United States for all PGY types, that is a lot of money. It's like in the ballpark of $30 million a year that the overall union has to work with. It's also probably justified. I think that when you go to your hospital and you beg for additional FTE or support, I think that especially in surgical subspecialties, the hospitals recognize the value that what they get from a resident who's willing to work up to 80 hours a week, take call on nights and weekends, that to try to replicate that with other sources of physician expanders or advanced practice providers is exceptionally expensive. And while you do have junior residents that probably for most specialties are not so much of a net positive for productivity, for all of us who work with residents and you have a chance to work with your senior resident or with a fellow, in many cases it's like working with a junior partner, and they definitely expand our abilities. Perfect example is from University of New Mexico, who lost the accreditation for their neurosurgery program. It took 23 APPs to replace their 8 residents. It also, if it was the money loser that a lot of the institutions like to present facing forward, you wouldn't have private funding programs like HCA, which is the largest residency program coordination in the country. You would not have them funding residency programs. It just would not make sense to do it altruistically or for any of the other reasons. It clearly is financially viable for them. And at least in this last year, about 5% of the residency programs across the company are HCA supported. Now, the big caveat here is that I think the understanding of how residents get funded and supported is vastly misunderstood by most people. And I'm not going to go through that with a tremendous amount of detail, but I think it is true that there is money that comes from Medicare in 2 different ways. One is direct support to support salary, and the other is indirect support that has a very complicated formula based on how large your program is, how many Medicare patients you see, and what your market share is. That determines, and that's where the real growth has been, because Congress capped the amount of salary support in the direct funding in 1997, and there's been very little of that that has increased. And so most of the growth and what comes to hospitals from the federal government essentially comes from increases in the indirect support. But back in '96, when this was capped, there were about 100,000 graduate medical education positions in the United States. There's now about 150. So that means about a 50% increase, or 1/3 of the residents that are out there, they're not supported from the federal government, right? Those are places where you've gone to your institution to either start a program or grow a program, and that additional support is coming from the institutions, with a small amount of it being due to a greater amount of indirect support. So my personal exposure to the unionization process, this is just a little bit about me. I was a resident at the University of Washington from 2004 to 2010. I went away for fellowship and then came back as faculty in the fall of 2011. And then we had a 2-year transition plan for me to become the program director that turned into 4 months, when the former program director became an associate dean, and then essentially the DIO and the vice dean of all GME. And so it was an abrupt transition, I would say. There was sort of rumblings behind the scenes for many years. The residents voted once actually to try to unionize and did not get enough of the votes to do it. So there was a failed vote. And then eventually they did get enough votes. And once that happens, then the process of actually forming the union and beginning negotiations took almost 2 years to do, actually. Before unionization, our residents across the university made about 53,000 as an R1 and about 62 as an R5. By comparison, the median salary in the United States for residents at that time was about $2,000 to $3,000 less, and we're in a very high cost of living area. So they probably were, though they were above the median, when you take into account the cost of living and especially housing, they were definitely behind. And we were often having times where we struggled to recruit folks who really liked Seattle as a city, but were sort of starstruck by what it cost to rent an apartment. The residents also got 3 weeks of vacation, and that put us at the 82nd percentile, which is kind of crazy to me to think that we were better than 82% of the programs that were out there, and they got less vacation time. The residents also had always gotten 17 days of sick leave that rolled and accumulated over your residency. That was very helpful when we had family leave issues, so that they could use that to be essentially paid family leave. And they also had a very reasonable healthcare plan which I didn't put on here, and they've had a 403B retirement with a 5% matching, which I felt like was sort of the most basic that you could potentially offer. But as I'll show you later, there are lots of programs where they don't offer most of these things, actually. In urology, we did several additional things to support the residents. We had a professional development fund that the faculty and some of our alumni had contributed to, that were these really small little endowments that made it so that the residents had $1,000 per year that they could use for various things. So as an R1, it was allocated to Campbell's. As an R2, it was allocated to Loops. As a 4, it helped to support their trip to the AUA. And then as a chief resident, it helped to support the board review course. We had some of these other things. As a state institution, we're not allowed to pay for parking, but if residents had one side of practice where they had to pay to park and then had to go somewhere else, or if they had to go across the 520 bridge to go to Bellevue to the surgery center on their children's rotation, for example, we would cover that. That was very much used. I'll just have you hold that in the back of your mind, the professional development funds part, because it'll come back here in just a minute. And so in January of 2015, they started the process of the first round of collective bargaining, and it truly was like herding cats. I mean, it took almost 2 years. There were 3 different groups of resident leadership. They were completely unorganized. They did not have anybody helping them with mediation, or the university actually, once they got over a year into it, offered to help bring in someone just to help keep them focused and on task. But there was a huge reluctance to make decisions as they got to a place where they had to decide which is more important, a bike fund or childcare. And they wanted to represent all of their membership, and they didn't really have a way to know which was more important. So instead it was both, and then both, and then both. And there was a reluctance to sacrifice anything to focus on other things, because they struggled to speak for the group. Through this whole process, the prior contract was fixed, and so there were no cost of living adjustments or any changes to the salary or their benefits during the negotiation process, because until a new contract, which there was a contract every year, till there was a new contract, you basically carried forward what was there from prior. Their priorities, if you asked them, you can see this is like, we just want more of everything. But I think it was the most important, I think, was focused on salary. But they had gripes for sure about some of the benefits, about parking, about childcare. They wanted support for, within urology, we were really good about supporting our residents to go to meetings, but I think that was definitely not true in other subspecialties. And then they also had some things that they wanted to have policy changes about. And I think these were probably the lowest hanging fruit and probably the easiest to give. They had problems with the grievance process. And that is a very fascinating thing, because of all the union leaders that they've had, which there have been like about 7, every one of them but one has been in the process of grievance, either on probation or going through an appeals process. It's fascinating. And so they had big gripes, I think, from a small number of people who were well represented in the union about how that process went, what their voice was, how they could appeal, who was on the committees before all this started. When someone was going to be terminated, there was not a resident on that committee, which of course there should be at least one or maybe more. The negotiations were very skeptical. I think even when the institution was really there was actually nothing that the institutional negotiators, which they had a consistent team all the way through, that they proposed as a compromise or a suggestion, even a suggestion of like, you should get representation to have somebody help you with this negotiation process, so that when your leadership changes every year in July, you have some memory, some institutional memory for that. They just felt like they were always trying to be tricked, They didn't believe anything that was said. When the institution would come with, examples of what work hours actually looked like, or how much leave folks were actually taking for family leave, they just felt like there was a complete lack of trust. And I love this little emoji on the left side, because what I learned right away as a complete outsider to this first round of negotiations was that oftentimes the loudest voice in the room was the one that was most likely to be elected to be the representative or the president of the union, but they were not necessarily the best person to go through a negotiation process, because some of those things that make you a very loud, I don't know, the emoji guy on the left, are not necessarily things that make you a good person who's able to find a middle ground and come to a conclusion. So in the end, the first contract was a 3-year contract. They got an immediate 3% bump plus 3% per year over the life of the contract. They got a lump sum ratification bonus. The contract also included what they called a home call stipend and a travel allowance. And so the first year, the home call stipend was $900. That was for any trainee, whether they took home call or not. And then it increased over the life of the contract up to about $1,150. There were 2 funds of $50,000 apiece to support better places to keep your bikes and to encourage biking and having the bike lockers, and then also a child care support. There was also this new idea that came through the union that got implemented across all of the programs of Professional Development Fund, and that was $350 for each resident. And you can imagine that if you were a internal medicine or a pediatrics program that has maybe 100 or over 100 trainees, that this was a big additional cost to the programs. We also now cover their medical license, and we pay for step 3. That's a one-time cost, of course. When they finished, I think that everybody was really relieved that it was done. And then the negotiators and part of the GME team then turned to programs and let us know that they had negotiated on our behalf, but there had been zero discussion about who was going to pay for which parts. And so in the end, the programs ended up covering the Professional Development Fund, the license, and the USMLE, and the institution covered the other changes, but it was also a complete surprise to everybody. The second and the third bargaining agreements that have gone through, they've gotten quite a bit more efficient. So with the second round, it was still 32 negotiation sessions, but it only took a year, and it was one group of residents. They ran it from July to June, which was a much better way to potentially do it. And then in the third one, they had 13 negotiations. They started late again for this one. They started trying to negotiate about 6 months before, but the union leadership was totally had their heels dug in about whether the sessions were going to be during the day or after hours. And I actually don't remember. I think they wanted them during the day, and that then they would be off service, and because after hours would be like extra work beyond their work day. And so in the end, they ultimately agreed to do them half and half. But they moved to this statement, which is last, best, and final, which basically from the institution standpoint is like, this is our best offer, and we're basically done negotiating. They did get a mediator for the final sessions, which I think was also hugely helpful. And you would think, just before I move on, you would think that with obviously the negotiation team from the university side is pretty much the same group of people, right? They've done this 3 times, but it's brand new every time for the union, because within 3 years, all of the union leadership has changed, and 60 or 70% of the residents have changed. So this is their current contract. They again still get 3% per year as an adjustment. You know, the R1 to R5 salary is now 67 to 79. It's now about $7,000 to $9,000 better than the median as everybody's salaries have gone up. They smush together the home call and the travel, and they get $8,500 this year for that. They sacrificed the bike fund and instead took a U-Pass, which is like a mass transit pass for everything in Seattle, the bus, the light rail, et cetera. And the vacation moved to 4 weeks, which puts us at about the 97th percentile. So there's no question that the residents get better salary and benefits, and the changes happened much faster than they otherwise would have. I think in my mind, as somebody who observed, there definitely were benefits for them. I think also the additional stipends help to level the playing field a little bit for the cost of living in Seattle. And organized power can be really good when it's, and I put organized in italics there because, of course, if they're organized, it's going to be more functional. It's great to have a collective representative voice when the institution wants to do something like move to a new site. The residents do COVID moonlighting, and they got paid market rate for that. So during COVID, they would, varying depend on the acuity of the patients and the duration of the shift, they could moonlight internally for around $2,500 for a shift. And certainly the representation on the committees and the grievance process were also positives. But I will say, every year that they go through this negotiation process, you hear, it is in the union leadership's best interest for there to always be something to fight about. And so these were things that you would hear all the time, and they would get louder and louder, especially in the years where they were going through negotiation. It also has now spilled over into social media and is very public. This is just from about 2 weeks ago, as the University of Buffalo is going through this process. And these are news outlets. These are also residents from University of Buffalo. There was a post that said, "My greatest wish for the match this year is that nobody matches at University of Buffalo," from one of their own residents who is there currently. It's pretty bad. This was posted in one of their websites. It's a comparison of what are the benefits at University of Buffalo versus 4 other institutions that are within an 80-mile radius of their program. And you can see, like, they should unionize. I mean, it's crazy. No retirement, no HSA, no meal stipends. Their healthcare policy, now POS doesn't stand for piece of shit, but I would argue that that is what their healthcare plan is, right? And you look at these other places, some of which are private, some of which are academic medical centers, some of which are state institutions, and it's astounding how different they are. So there's also the consequences of some animosity, especially in the contract years. Our residents have not ever, they have threatened to strike before, but they have a no strike clause. But they have done sneaky things, like they have a personal day and they try to all coordinate to take their personal day all on the same day, like across the entire institution. And I would say that not only is it more difficult to expand your residency now because there's greater costs from FTE and all the other support we have to do, but there's also this reluctance to do anything extra because there's a fear that there's pressure from other subspecialties to say, like, don't do that because otherwise we're all gonna have to do it. That's it. Thanks.